So adenomyosis, as you all know, is endometrial tissue within the musculature of the uterus. So a little bit different etiology than fibroids, but present in a similar age group. So women aged 40 to 50 roughly also presents with similar symptoms. So abnormal uterine bleeding and dysmenorrhea. Now the pain component in adenomyosis tends to be a little bit more severe than it does in fibroid disease. So adenomyosis also overlaps with other gynecologic disorders, not only in the symptomatology, but actually in the presence of it. So meaning it's found concomitantly with fibroids, not infrequently, and it can be seen with other things such as endometriosis. Again, not only do they concur or they happen at similar timing in patients, but they also just have similar symptomatology. So sometimes even if they're not present together, separating them out can be very difficult. This is just a very simple graphic of what adenomyosis looks like. So normal uterus on the left, adenomyotic tissue on the right. So you see those little cystic spaces and expansion of the junctional zone that you see in adenomyosis. Now we'll look at that on imaging. So on the left side of your screen, this is a fluid sensitive sequence. You see that expansion of the junctional zone. And in both that image and the middle image, which is post contrast, you see those small cystic spaces that we saw in that graphic on the previous image. And finally, on the right side, this is an MRA. And the only reason why I show it is just remember that your MRAs on these MRIs can be very helpful, not only for fibroid disease, but actually for adenomyosis as well. So if you look, you can see down below, you see those tortuous classic appearance of the uterine arteries inferiorly. But you can also see, particularly on the left side of this patient, so on the right screen, but left side, the radiology left, you can see this large tortuous ovarian artery going down to the uterus. And so even pre-procedurally, you're thinking about, could that actually supply the adenomyotic tissue? These are our images post-embolization, and I'll tell you that this was a diffuse adenomyosis pattern and got really great embolization compared to some patients. This is not the typical appearance post-embolization. This looks much more like fibroid disease in a sense, and you can see on the right-sided image, the area of normal uterine tissue is just that very small white rind of tissue that remains enhancing. The rest of this was adenomyosis. And like I said before, often what we get with adenomyosis in terms of infarction on MRI afterwards is a heterogeneous pattern. It doesn't always look this severe. This happens to be one of my better cases. So regarding adenomyosis, how well do we do? And, we've talked about our efficacy in fibroid disease, but what about UAE for adeno? So this is a little bit harder of an area to study because adenomyosis in its pure form is very difficult to find. As I mentioned before, it often is seen with fibroid disease and other disorders. So this, the data we have for this is mostly pooled data. If you look at the systematic review, in the short term, symptom relief was about 83% overall. Now, the best data that we see is in patients that in the short term that have combined adenomyosis and fibroid disease. And that we achieved about a 94% symptom control in this meta-analysis. The worst data that we see, or the worst symptom control, is when we look in the long term and in the pure adeno group. So the way that I describe this to patients is we have really great efficacy in the short term, but often women will recur with symptoms, or only about 2/3 of women will we keep from having another intervention. So that's still pretty good, whether they end up having another UAE or they go on to hysterectomy later when they feel more comfortable with that. But either way, we get a bit of a drop off in the success rate in comparison to fibroids. However, 2/3 isn't so bad, or 3/4, however you want to look at it. But depending on the study, somewhere between 2/3 and 3/4 of patients maintain their uterus and with good symptom control with UAE for adenomyosis. Most of you probably have heard about the step-up protocol regarding the treatment for adenomyosis with UAE. And so this is a paper that came after the step-up protocol, just talking about a new development in the step-up protocol and some findings that were identified. So this was specifically 40 patient prospective study. They actually looked at pure adenomyosis patients, and that's why the numbers are a little low, but for pure adeno, a 40 patient study is actually quite big. And they used the 1, 2, 3 protocol. That's the step-up protocol that was previously published by the same group. And just remember, one of the points that I always like to make when talking about the step-up protocol, it's often misconstrued, and people think about starting a particle size in the 100 to 300 size range when they're thinking about things like embospheres or some of the other microsphere particles. And in actuality, this trial, the 1, 2, 3 was named for PVA. And we know that PVA functions very differently than other microsphere products. So just remember that the 1 in the step-up protocols for 155 PVA, the 2 is for 255, and the 3 is 350. So just remember, it's named for PVA. And if you're thinking about using something other than that, which I do, but depending on your preference, if you're using an embosphere or hydropearl or something along those lines, you want to be thinking about more of the 300 to 500 range to act similarly to that 155 PVA. So what did the outcomes show? About roughly 83% of patients had complete necrosis of their adenomyotic tissue. So that's pretty good. And what they distinguished in this extra factor, so what this breakout group looked at, was actually the differences in signal intensity on MRI and how that type of adenomyosis treated in these 40 patients. So for those patients who had dark signal intensity on MRI of their adenomyotic tissue, they actually treated 100% necrosis. And remember, this is a small study, and particularly the group of those individuals who had dark signal intensity was small. However, there may be some signal here showing that we can distinguish between different types of adenomyosis on MRI, and that some may achieve better outcomes than others. So I didn't show you a UAE case because I know you've all seen UAE with regard to fibroids, but this is a UAE case with regard to adenomyosis, and not as many people have treated adenomyosis, or at least not frequently. So I wanted to show you what it kind of looks like. So these are the on the left side of your screen is the right uterine artery, and then of course the left uterine artery on the other side. And so just to give you some idea, when you look at this, this is not normal myometrium. And the reason why I say that is if you see normal myometrium, when you look at the uterine arteries for normal myometrium, they're very non-globular. So the vessels are kind of linear, and other than the main uterine artery, the vessels to the myometrium are kind of linear and narrow and spaced evenly. You can see here that there's sort of this globular appearance that doesn't quite look like fibroids, but it's a globular appearance nonetheless of the parenchymal enhancement of the uterus. And this is because of the adenomyosis. And so what I'll show you is just to give you an idea post-embolization of sort of where you stop, but also just if you look at the ends of these images, that's normal myometrium. So that's smaller, more inferior stuff that has more uniformity in the vessel rather than that globular parenchymal enhancement that we saw in the previous images. And this is sort of where you want to stop post-embolization. That's sluggish flow in the uterine artery, but preserved flow to the myometrium. Now, I mentioned before that our MRA can be really helpful, not only in fibroid disease, but also in adenomyosis. And this is because I can't tell you how many times I've treated adenomyosis and actually seen that an ovarian artery supplies the adenomyotic tissue. So here, this was suspected on the MRA, so I did an aortogram, and you can see both actually ovarian arteries are enlarged here, and so both really needed to be investigated. Now, I'll say the right one certainly, depending on the criteria you use, and what I typically use is, does the ovarian artery fill in the pelvis at the same time the rest of the pelvic vessels are filled? And you can see on the right, it sort of does. On the left, it's a little bit more delayed, but nonetheless, both of these are pretty hypertrophied and deserve an interrogation. So I took a look at the right one, which happened to come off the right renal in this case, which isn't typical. And you can see here that when you investigate and get selective in the ovarian here, you can see that's more than just an enhancement of the ovary. So there's definitely some of that arching vasculature going over to the uterus. So I thought that this certainly supplied some of the adenomyotic tissue. On the left, maybe a little less so, but again, I still think that there's a little more than ovarian tissue being enhanced here. And some of that tissue going into the uterus, I think, was being contributed to by this ovarian artery. And so afterwards, this is where I stopped post-embolization. On the right, I took it to a little bit more of a static degree in terms of at least getting all that uterine tissue embolized. On the left, I kept it to where I thought that at least the ovarian tissue was still getting enhancement. If you look at the data, we know that if we treat one ovarian artery, we seem to not have any impact on fertility whatsoever, or on ovarian reserve, I should say, is a better way of saying that. Whereas if we treat two ovarian arteries, there may be. So I tend to treat one if I don't think the other one contributes, but I always have this discussion beforehand so that I have the liberty to treat both if I think that they both supply, whether it be fibroids or adenomyosis. In this particular case, like I said, I took it to a little less static degree on the left ovarian to try to preserve that ovarian tissue. So what do I think the future directions are for adenomyosis? Certainly we're not as far along as we have been for fibroid disease. I think one of the difficulties we struggle from here is not only, as I mentioned before, that a lot of the women we studied don't have pure adenomyosis, but also we just have no MR classification system for it. When you look, some people have adenomyotic tissue on one side of their endometrium, but not on the other. It may be sort of diffuse, it may be sort of focal, there's all these different things, and we have no way to really describe that or define it. And since we can't do that, we can't really break down, what women achieve a good result from a UAE if we're not really able to define them into categories with a standardized classification system. So I think that's coming down the line. I think, Maureen Cohey is the lead investigator for an RCP coming in, a research consensus panel done by the SRR Foundation in May. And I'm the junior investigator for that. So I think what is nice about this is we're going to get a panel of people together that come from the gynecology space and from the IR space and even family practice, and discuss what's next for adenomyosis. What do we need to do to really look at uterine sparing treatments of adenomyosis, in particular UAE, and what do we need to study to actually know whether this is helpful and for what patient population this is helpful for. And then what do I think that will ultimately lead to? My guess is it'll lead to an adenomyosis registry, just given the difficulties that I mentioned before in the patient population. But, we'll see. And that's what's so exciting about being able to do an RCP, is to get all the experts in a room and discuss this, and not from just one discipline, but from a multidisciplinary team.